School at the University of Calgary and neurosurgery and interventional neuroradiology training at the University of Toronto. He has worked at Yale University since 2012. Dr. Matouk currently serves as the Vice Chair of Clinical Affairs for the Department of Neurosurgery. He also serves as the Chief of Neurovascular Surgery and the Director of NPH and Disorders of CSF Dynamics Program. His focuses have been on clinical program development and clinical trials, both design and conduct. He is involved as a site PI, or in trial leadership for several interventional stroke trials, including Complete, Thunder, and Mars. He's currently serves as the co-global PI for Revive, Terumo Neurovascular's upcoming IDE trial for their ultra-large bore Sophia 88 catheter for mechanical thrombectomy and stroke. We're excited today for his talk on mechanical thrombectomy, what we should be striving for, and how to achieve it.
Well, thanks so much, James, for the kind introduction, and thanks, Cam, for having me. I'm going to share my screen. Let's see. All right. And let's go to here. All right. Can you guys see that?
Yep.
All right, wonderful. So what we'll talk about today is something that I've been interested in for many years now, which is mechanical thrombectomy for stroke, and in particular, what we should be aiming for when we enter the procedural suite and how to achieve it. And I think my thought process on this subject has evolved over the years. It's going to continue to evolve, and I'm hopeful that at the end of this little lecture and discussion that you'll at least have some guiding principles for those of us that do this for a living. So I have, I'm hopelessly conflicted with a bunch of number companies. Many of these companies are related to stroke devices or neuroprotection strategies. And I'll leave this up here for 2 seconds just so you can digest it. But I don't think anything I'm going to say today is influenced by any particular company. The way that I've organized this is I'm just going to give you some context for my thought process, and that's really my clinical practice. The way that I've approached my academic neurovascular career is to really have all questions come out of the clinical practice that I choose to focus on. And that I think makes it much more enjoyable for me and much more relevant, I think, to how I approach things in day-to-day practice. So it's in that context that I'll introduce the principles that I think are worth thinking about how to achieve procedural success, or first, how to define procedural success. And we'll focus a little bit on TICI grading, something called first pass effect, procedural time, and then this newer concept that we proposed about a year ago called FPE 30, or first pass effect 30, or within the first 30 minutes. In the last part of my talk, I'll introduce 3 sort of like newer technologies that are emerging, I think, as potential game changers, or things that will impact our ability to do mechanical thrombectomy procedures successfully. So let me start by first introducing this slide. So I'm going to take you through the first left side of the graphic here slowly, but it's basically captures my practice from when I started at the end of 2011 at Yale, and then goes all the way to 2021. Now, this isn't like our total procedural volume at Yale, but it really focuses on me. Because I want to show you my sort of evolution and thought process over time. So on the x-axis here, we have years. These are years that I've been in practice. And these are the number of thrombectomy procedures that I performed in any given year. And the different colors on this graphic are meant to represent the different mechanical thrombectomy techniques. So dark blue is a stent retriever strategy. The red or maroon color has to do with the Solumbra technique. So that's combined stent retriever and aspiration. And then the lighter blue here is an aspiration first strategy. And you can see when we started in practice, this is even before the foundational trials, which were published in 2015, we were doing some mechanical thrombectomy. And there was essentially, we were basically using exclusively stent retrievers. And that was our first introduction, both in Canada and then again, where I trained. And then again, here in the US, we were doing stent retriever, basically strategies. I think we were doing so much solitary use in our first few years that we were like one of the highest accounts for Medtronic and their solitaire device for a couple of years before other centers sort of caught up. And it was a very effective strategy. In about 2015, we started to use the Celumbra technique as novel aspiration catheters or distal access catheters became available. And so our use of the Celumbra technique increased a lot. And in about 2018, we participated in one of our first trials, which was a post-market registry trial of penumbra aspiration catheters and a penumbra stent retriever called the 3D retriever. And what we realized at about that time was that most of the time the clot was coming out within the aspiration catheter or was lodged in the tip of the aspiration catheter as opposed to being in the stent retriever. And so that made us think when that trial was completed that we were going to move to an adapt technique because maybe that's all that was needed. And there was this rapid evolution at that time as well of technology that made aspiration catheters so much more navigatable up to the relevant, to the target clot. And so I would say nowadays, my practice is essentially 95% aspiration first. I actually can't remember the last time I used a stent retriever outside of a suspected ICAD case to sort of confirm the diagnosis. So we've really sort of, embraced this adapt or aspiration first strategy. And one of the main reasons for that is that when we looked at our data, we noticed that I was much faster, essentially using that strategy. And, it made me wonder whether or not being faster mattered. So just to take you through this right side graphic, this is a density plot. And on the x-axis, you have procedural minutes. So this is groin puncture to complete revascularization. So from 0 minutes to 200 minutes. And this is the probability of the event happening, right? So the higher up on the y-axis you are, this is like the higher, concentration of cases there are essentially that fall into that bucket. And again, the colors here represent in green aspiration first, in blue is the combined technique, and then in red is stent retriever. And what you see here is that with the adapt or aspiration first technique, the cases really concentrate within just a few minutes of procedural length. Whereas with the stent retriever technique, you don't see nearly this sort of peak. It's more evenly distributed across a longer time period. And there's a much longer tail that goes out to, much longer periods of time. So we thought this was an interesting observation. I'm certainly not the first to make it. I can remember Don Fry at different meetings doing like races in the early days, to tell people that aspiration was the way to go. At that time, I saw no reason to change because we were having success with stent retrievers, but it was really me being involved in a clinical trial that sort of like opened my eyes to this other possibility and really made me think like, does this matter? Like, yeah, sure, it's nice to be quick, but does being quick make a difference in terms of patient outcome? So, oh yeah, so and just for reference here, we have like an on-off call schedule at Yale, so I'm basically on every other week. So over the years now, I've done over 800 mechanical thrombectomies for stroke. This is going to have to calm down at some point because I don't think I can sustain it much longer. But that's sort of been my life for the last decade or so. So I'm going to introduce this slide now, and then I'm going to take you through a whole bunch of evidence about why I think this way, and then we're going to reintroduce this slide at the end of the talk. But really, it's focused on this question of what I should strive for when I walk into the neurointerventional suite. And what I'll try to convince you is that what we want to do is have complete revascularization, so defined as TQ2C or 3. We want to open up the blood vessel in a single pass. That's called first pass success, which leads to the added clinical benefit of achieving that. That's why it's important. That added clinical benefit is called first pass effect, or FPE. And then we'll introduce a concept called FPE 30, which is there's the clinical benefit that's derived from achieving first pass success is modified importantly by procedural time. And we'll go through that in detail. And that's the graphic that I have illustrated here. And I'm going to walk you through it in a minute. All right. So I'm not sure why that just popped up, but okay. So what we'll do now, so it's in that context. So we're really like an aspiration first shop. And I was sort of like very impacted by the migration from stent retriever to aspiration first, was really basically showed us how much faster you could be. And then this desire to sort of like try to figure out, does being fast really matter? Or is it just a matter of like beating your chest? Does it actually impact patient outcomes? And so these are the sort of like important concepts that I think are worth thinking about that, and I'll try to give you some evidence for, why these things are important. A metric isn't important unless it correlates with improved patient outcome, right? So if you have a metric that can, show you something or help you grade something, and we have a lot of scales in neurovascular disease that I think are like not so helpful. Like an example of which is, for example, the Borden grade for dural fistulas, right? Like maybe it's just easier to say is there cortical venous reflex or not? Like why do we need a grade? But the classification of spinal shunting lesions of the spine are ridiculous, right? Like type 1, type 2, and then we have to memorize what those things mean as opposed to just saying directly what we're talking about. Those types of scales or classifications, in my opinion, are not super helpful. And especially if you're having a metric, you want the metric to be correlated with, something important. And that usually means turning the dial on a clinical outcome. So let's talk about the TICI grading scale. So it's important to remember that if we go back in time, so the original stroke trials, right? This now predates the foundational trials. For example, when we were using the Mercy device, which is what we were using when I was a fellow, those trials were designed in such a way that any partial or complete revascularization was the outcome of interest. So today we would call that TICI 2A, right, or above. And that's a good metric, right? The problem is that none of those patients really got any better, even though procedural success was achieved in 70 to 75% of the cases. And so it's great to have a metric that you can achieve or not achieve a majority of the time, but if it's not correlated with improved clinical outcome, then it's not such a useful thing to sort of think about. TICI-2B3 was introduced by the IMS investigators and those, of IMS3 fame. And that's really substantial reperfusion, where you had greater than 50% of the downstream vascular territory reperfused. And this was the outcome measure that was used in those foundational trials that were published in 2015 and really established mechanical thrombectomy for anterior circulation large vessel occlusion as being a standard of care. Mostly because it not only you were able to achieve technical success, but that technical success translated to improved patient outcomes, right, as reflected in the primary outcome. Nowadays, we talk more about TICI 2C to 3, which is over 90% of the downstream vascular territory gets reperfused. And why is that important? Like, why do we want to look at 2C3 versus 2B3? Well, the reason is that 2C3, if you achieve that, those patients en masse have better clinical outcomes than if you achieve 2B3 revascularization. And that was nicely demonstrated, for example, in the ASTER trial. There isn't much difference in clinical outcome between 2C versus TICI 3. And I'd venture to say that there's a lot of variability in how that gets reported. Right. So some investigators don't want to call something 3. Some investigators want to call everything 3. But it's very complete revascularization as opposed to more than 50% of the territory. Those patients, if you lump them together, the 2Cs and 3, that's what we should be sort of like striving for, as complete a revascularization as possible. Why? Because those patients do better en masse than if you only achieve 2B or better. Now, I'm going to say this many times, I think, throughout the talk. That does not mean that doing everything possible to the point of potentially harming a patient, to achieve that is the goal, right? The goal is to be able to get the QC3 as safely as possible. And if you can do that, then patients en masse will probably do a little bit better. So this is a nice review that was published a few years ago, describing some of the final TICI scores classified in these different ways in different studies that had sort of been published. So NASA, for example, was a post-market solitaire registry. And there's other studies that you see there that focus on both aspiration and stent retriever technology. And if you look here at this particular column where it says final TICI score, CHU beta 3, you can see that even in these relatively early studies, you're achieving a final TICI score of CHU beta 3 85 to 90% of the time, right? So by that metric, the technology is extremely successful. Now, if you just go to TICI CHU CETA 3, you can see that the percentage of those cases drop significantly, right? So that the number of these cases that were actually reflected in near complete revascularization was much less, right, than was encapsulated in this CHU B3 metric. So that suggests that there's a long way to go, potentially, for significant improvement in technique as it relates to this achieving this TICI CHU CETA 3 endpoint. And again, why do we want to achieve this TICI CHU CETA 3 endpoint? Because if you can, patients do a little bit better as a group. So the first sort of take-home message is that the completeness of revascularization matters, and you should have a goal of achieving TICI CHU CETA 3. It's a particular annoyance of mine that the clinical trials, many of which are run by industry, continue to insist on having TICI CHU B and 3 as their primary outcome measure, and then this gets couched as a secondary outcome measure if it's reported at all, because really I think nowadays this is actually what's more important. So TICI grade at the end of the procedure is one important measure of success. Let's talk about some others. So if completeness of revascularization matters, there's different ways to get there, right? You can do it in one pass or you can do it in multiple passes. And a question arises is, does that matter? When Osama Zaidat looked at the North American Solitaire Registry, so-called NASA, he made a very interesting observation, which was that if you look at patients that achieve complete revascularization or near complete revascularization, the clinical benefit that they derive is different based on the number of passes was required to achieve. So 1 versus 2 plus. And so he defined that added clinical benefit of achieving first pass success as the first pass effect. So to have that, you have to have single pass with a particular device. So 1 pass. You had to have relatively complete revascularization. So that's TICI CHU CETA 3 in the downstream territory, and no use of rescue therapy. So I want to take you through, let me see if I can do that. This graphic over here. So what you have here on the x-axis, and this was published in that original stroke paper that described the first pass effect, is that you have here, 2 different sort of data sets. So one here is MRS, so their clinical score at 3 months. So this is doing well, less than or equal to CHU. And then in black here, you have the mortality score, right? And on the y-axis is the percentage of patients that achieved that in the NASA registry. And if you look here at first pass effect, so this is like you open up the blood vessel completely, so you get TICI 3 revascularization with 1 pass. So this is the MRS. That's good MRS, so 0 to 2. And here, if you achieve the same complete revascularization TICI 3, but you did it in more than 1 pass, then your number of patients that achieve a good clinical outcome at 3 months is defined by MRS 0 to 2 decreases. Both of these are better than not achieving near complete revascularization. So if you have TICI CHU B, the number of patients that have a good outcome falls even more. And you see the inverse relationship with mortality. Well, isn't that interesting? So now it matters not only whether or not you've achieved complete revascularization, but how you get there. in one pass versus multiple passes. Once you do more than one pass, interestingly, the added benefit that you see clinically is gone, right? So again, we're not saying that there's no benefit, there's huge benefit, but the added benefit of achieving complete revascularization in one pass goes away if you achieve it in two passes. And then whether it's two passes, three passes, or four passes doesn't matter as much. It's something special about that first pass and achieving your complete revascularization that matters. So now we know that the completeness of revascularization is insufficient as a goal in and of itself. So complete revascularization should, if possible, be achieved in one goal. And I think that matters about our mindset going into a procedure, which is not just to take a swipe at the clot that's not an ideal pass, but to really strive for that first pass to be your best pass. Because if you can achieve it at a population level, when you look at your practice 10 years from now, you're going to have helped more people a little bit more by doing that. So now if we look at that same table that was put together by these authors very nicely, and you look at first pass TICI-2C to 3, you notice now that the numbers are much smaller, right? 15%, 30%, 20%, 25%, a couple of 40s in these very selected patients in a trial setting. And so we have a very long way to go to squeeze that extra benefit out of the procedure for patients that we're treating with mechanical thrombectomy. So the second takeaway point that I want to leave everyone with is that achieving complete revascularization in a single pass is better than in multiple passes, and that concept is captured in this notion of first pass effect, right? Which is the added clinical benefit that's derived by achieving first pass success with a mechanical thrombectomy device. So now we have two elements that we want to think about. The third element, and this has come up for many, many, many years, this sort of very unusual phenomenon that independent of number of passes is procedural time. So this is Alex Spiota's work when he was at MUSC. When he was at MUSC, that was published many years ago now. So this is back to 2018. He defined something called the golden 35 minutes of stroke intervention. And what he did is essentially took patients that either had early recanalization. This isn't from time of stroke onset, but this is from time of groin puncture to achieving whatever the final revascularization was. If you look at patients that you did this quickly versus not quickly, and he defined that cutoff as 35 minutes somewhat arbitrarily, you can see that many more patients have a good MRS, that's in blue and red, versus if you have longer procedural times. And this seems to be independent of the number of passes, at least in this data set. And so that was like another wrinkle now, is that this idea that sort of like initially sparked my interest in these concepts at all was that, well, maybe the speed of a procedure, does matter. Another way to say that is maybe intravascular dwell time does matter in these patients with vulnerable brains that have an occlusion, that are dependent on collateral circulation. Maybe by spending a lot of extra time in their blood vessels, that's not a good thing, right? Another way to think about it is that, let's say you had a patient that came in with a complete occlusion, let's say if an M1, and you took that patient to mechanical thrombectomy and didn't get the blood vessel open. And then you looked at a patient that had an M1 occlusion and you put them in your neuro ICU and you monitored them over time. It turns out that in general, if you try to open up the blood vessel and fail, that those patients do worse than if you had left them alone. That emphasizes this idea that the only reason mechanical thrombectomy is good is because opening up the blood vessel is such a powerful predictor of better outcome. But if you fail to do it, you actually then expose that being in our room in the neuro IR suite is actually a vulnerable time for these patients. And that procedure time then might matter if we can reduce that exposure as much as possible. This is beautifully put together by really a resident still. I think he's still a resident, soon to be fellow at MUSC, Ali Alloway, who was a disciple of Alex Spiota. So he's at Emory University now. And what he did is in a rigorous way, and I'd encourage you all of you to look at this particular publication that was recently published in the Journal of Neurointerventional Surgery, that showed that the actual impact of procedural time is likely greater than time from stroke onset to reperfusion. Again, emphasizing the importance of procedural time in patients' ultimate clinical outcome. So we shouldn't care about procedural time unless it matters. And it turns out that not only does it matter, but it's probably a disproportionate impact on a patient's outcome after a mechanical thrombectomy procedure. So the number needed to treat showed that 10 patients need to be treated at fast tier centers. And you can see the numbers that we're talking about. I'm sure everyone on this call is a fast tier center, so it doesn't necessarily resonate with you, but that's not reflective of the practice at large, right, in a broader sense. To achieve one additional good outcome compared with slow tier centers. So this really, I think, changes fundamentally how we think about triage. I think this is going to be extremely controversial, but this storyline has been building for almost a decade, and the data is pretty solid and irrefutable, even though it's potentially not convenient and, as a result, controversial. So the third sort of point then is that we talked about completeness of revascularization, how you do it, one pass versus multiple pass matters. And now we've added this wrinkle of procedural time seems to be associated with better clinical outcomes. And what we then sought to do is to see whether or not there was a relationship, right, between procedural time and the clinical benefit someone derives from a mechanical thrombectomy procedure as it relates to this first pass success effect that we see. So another way of saying that is, does procedural time modify the added clinical benefit that's realized by achieving complete revascularization in one pass? So this study was led by one of our superstar residents and an enfolded endovascular fellow, Andrew Koo, who's actually going to do his open neurovascular surgery fellowship at NYU with Erez Nosek, and a brilliant, I would call him a methodologist, a quantitative thinker, Adam de Havilland, who's a brilliant stroke neurologist here at Yale. And what we did is that we leveraged the STAR database, which is a large retrospective real-world data set that has over 10,000 thrombectomy cases from around the world. And we selected out patients that had near complete revascularization. So I'm gonna walk you through this graphic. This was published in Neurosurgery about a year and a half ago or so. And so it's available to sort of go through in detail for those of you that are interested. But this is the key figure, and I'm going to walk us through it slowly. So everybody in this chart has achieved near complete or complete reperfusion, right? So TICI 2C or 3. So that's everybody that you see in this graphic. And on the x-axis, we have procedure time from 0 to 60 minutes. And on the y-axis, we have the predicted probability of a good outcome, which is defined as an MRS of 0 to 2 at 3 months. So the higher up you are on the y-axis, the higher a probability of a good outcome you have. Okay. We have two groups. The group that's in light gray had achieved complete revascularization or near complete revascularization in one pass. And this group in dark gray achieved complete revascularization in multiple passes. And immediately you see that the added clinical benefit, so the clinical benefit that you achieve by opening a blood vessel up completely in one pass is importantly modified by time, right? So if you achieve complete revascularization in 10 minutes, that's better than if you achieve it in 50 minutes. Even though you've achieved first pass success in both of these patients, the amount of time it takes you to do that is reflected in how the patient does in 3 months, which is crazy. That effect, that modulatory effect of procedural time when there's multiple passes is very much blunted. So once you lose this idea, this added benefit of achieving first pass success, that Osama Zadat principle, time is much less important. But that added clinical benefit that's realized by achieving um, complete revascularization in one pass is time dependent. And so we call this little segment over here the true first pass effect, which is really that added clinical benefit of not only achieving complete revascularization completely in one pass, but also quickly. What does quickly mean? Well, these lines cross at 27 minutes. So it's very reminiscent of that original 2018 Alex Spiota paper from MUSC, where they arbitrarily used 35 minutes as a cutoff, right, for when patients do en masse, right, at a population level, a little bit better if we can do things quickly from a procedural point of view. So we call this now, we could define a new metric, which we call FPE 30, so first pass effect in 30 minutes, which is really now meant to reflect your ability to open up a blood vessel completely in one pass within 30 minutes, because we think that those are the patients that are likely to do the best the most often, or the most amount of better, right, more often. So the fourth takeaway point is that you shouldn't drag your feet when doing these procedures. So first pass success is key, but you do want to achieve it as quickly as you can if you want to realize the greatest benefit, for your patients at a population level. All right, so that's all about how I define in my brain first pass or procedural success. And those are the four principles that I think about when I go into a mechanical thrombectomy procedure. And those principles will not only guide how I approach the procedure in general, but will approach also like how many passes I think I'm going to do in the context of, what is the patient's neurological deficits? How likely am I to hurt them? How likely is there to be a complication, et cetera, et cetera. But those are the principles that I have in my mind when I'm thinking about what does it mean to be successful after a mechanical thrombectomy procedure. Now, the second part of this, which I'm hoping to wrap up in the next 10 or 15 minutes, is going to be, well, how do you achieve that? And I think that, again, because my context is really aspiration first, and if we have stent retriever first people, on this webinar, I'd please welcome you to point out to the group what you think your best practices are. But from an aspiration world point of view, I think there are some keys, which was you want to use the right size aspiration catheter. So, I mean, it's intuitive that you don't want to force things, right? So things need to be able to get there reasonably well, but you want to right size your aspiration catheter. You certainly don't want to necessarily undersize your aspiration catheter too much, because the power of aspiration is really exponentially related to the diameter or the radius of your aspiration catheter. So even a little bit of a bigger catheter, if the vessel will accommodate it safely, potentially affords for a greater likelihood of achieving first pass success. The other thing that's come about in the last few years is modern delivery catheters. So whether you're using distal access catheters or these sort of novel delivery catheters like Sendit or Tenzing or a carrier, or there's a million different iterations of these different delivery catheters, they really have changed how easy it is to get relatively large bore or super bore aspiration catheters to the clot face, how easy it is to navigate distal vessels with smaller catheters more safely and avoid ledge effect at branch points. And then the third is, of course, you want to have an efficiency mindset, right? Is that informed by these principles, you want to set your first pass up for your best shot at getting the clot out, and you want to try to work efficiently because the time in the vessels, the intravascular dwell time, the procedure time, is an at-risk or vulnerable time for our patient population. There are three, I think, new technologies that are sort of in their early stages that I think will have a huge impact on, or a huge potential impact on how successful we are during our mechanical thrombectomy. So to achieve the procedural success that we defined in the first half of the talk. And those are really alternative access, the emergence of something called superbore catheters, and then this concept of modulated aspiration. And I'll try to just give you a brief introduction to the three of them. So back in we'll start with alternative access, and I'll focus here on transcarotid access, but transradial access and its variations are also other forms of this, right? So choosing which access is the best and is going to reduce the procedural time, I think, is a noble aspiration, because we said that if these things can all be done safely, we now think procedure time matters, right? And setting our first pass up for the best chance of getting the clot out completely is important. So back in circa 2018 or so, 2019, we sort of had made our switch to aspiration catheters. And aspiration catheters are by definition larger than the stent retriever catheters. And we found it very difficult in complex arch anatomy, if there was a lot of tortuosity in the great vessels of the neck, to sometimes advance an aspiration catheter up to where it needed to go, especially with technology at that time. And so it was frustrating when you had a simple M1 occlusion, but you just couldn't get up to the clot to do a pass, or you were spending extraordinary amounts of time and multiple catheter systems to cannulate the origin of a common carotid artery in a way that was stable enough to advance these large catheter systems over the into the clot. And so what Brandon Cord, who was one of our fellows at the time, he now works at UC Davis, looked at was our data set on percutaneous transcarotid access with a bright tip sheath, closed either using an angioseal closure device or manual pressure. And what he did, and that's what's shown in the shift analysis at the bottom of the graph, or the bottom of the figure, the top line of which is direct carotid puncture, and the bottom one are patients that we aborted the mechanical thrombectomy. So we couldn't get there. We didn't want to do transcarotid access. This is really pre the popularity of transradial access. And we just compared their MRS at 3 months. And, it's not difficult to imagine that if you opened up the blood vessel in these difficult access cases, as reflected by the light blue boxes on the left side of that shift analysis, patients did a lot better than if you didn't open up the blood vessel. Totally intuitive. But it meant that you can do these procedures, like these transcarotid access, you're going to help more patients, right? Because you open up the blood vessel, and if you open up the blood vessel, that matters, right? The problem with this particular technique is that we had a number of patients that had hematomas. And just so you guys understand about the hematomas, is the hematomas incites the laryngeal edema and closes off the airway, and people can asphyxiate to death. And we had a patient that had this type of transcarotid procedure done, the percutaneous one. And we closed with an angioseal, and she did amazing. She actually had one of these miraculous recoveries in stroke. And she had a carotid blowout on day 3, and she died, right? And so it became very clear that, MacGyvering these systems in ways they weren't intended to use, and addressing the issue of we don't have a proper closure device. The red arrow on that graphic shows a mal-deployed angioseal that at the time I would have taken to surgery and plucked out and just put a stitch in the vessel. So you can see that, that the foot plate is like is not is like digging into the vessel wall in a sense. Um, that that this is probably not the best system to use, even though it's better than not doing anything. At the time, we were doing a lot of these transcarotid artery revascularization procedures, and but basically, it's an open carotid access to the common carotid artery just above the clavicle. And so we approached the company about adapting this technology for use in a stroke population. There's little things on it that make it like not convenient. So we adapted that particular the en route sheath, which is the one that's marketed. We made subtle adaptations to sort of optimize it for a stroke procedure. And we ran a clinical trial called Night One, which enrolled at 5 different centers in the US, had trouble recruiting, but essentially used this open transcarotid access system to do a mechanical thrombectomy in acute stroke in patients where we were struggling to get at. One of our fellows at the time, Nanthea Sujijuntarat, who's now come back to us, and she's an attending at one of our hospitals, wrote this up. Still trying to find a good home, but I think the results are extremely convincing in that I think patients, so very few access site complications. We were able to achieve first pass success in 2/3 of patients using standard bore technology. So that's better or as good as if there was not difficult access. And patients, I would say, did better than expected and had less stroke than expected on their postoperative MRI scans that were done as controls. So I think that it's not going to be adopted by the world at large until it becomes percutaneous, and that's coming, I think. But this was, I think, a step in the right direction. Again, with this concept that it is better to do these things and to use alternative access than not open up a blood vessel. And if you have that sort of mindset, it's not like really like a huge leap of faith to say, like, well, if you think procedure time is important, then it's not so much can you get up or can you not get up, but what allows you to get up and do the procedure faster. And then that becomes a more interesting conversation if you believe that procedural time is important. The next concept is these superbore catheters, right? And so this is getting a lot of attention, I think, in the field at the moment. There's naysayers, there's yaysayers, but these are ultra large bore catheters, right? So the 88s, the 92s, they're very large catheter systems. And so we were involved in the early stages of the Millipede, which is one of these very nice large bore systems. Super bore, they call them. This one's called Millipede. It's made by a company called Perfuse. And this was like their first sort of in-man experience that was recently published in Interventional Neuroradiology. And you can already see here that the reperfusion using Millipede in terms of the first pass success rate, this is near complete revascularization in one pass, is now at 73%. So it's starting to move the needle on first pass success. And I think that is something that I think is very attractive if it turns out to be true. So it's not clear. This probably results in complete clot ingestion. Very often, when you use superbore catheters, you don't get the corking of the clot in the tip of the catheter. It just comes through and it empties out into the pump or the syringe because they're so large bore. So I think this is more of an ingestion as opposed to like a corking. But I think I'm very excited about this particular technology, and this is one of the trials. There's a follow-up study to this called Mars that is yet to be published, which I think is the prospective study. This was a retrospective study, which I think will be very exciting to see. And then I'm helping Penumbra, or not Penumbra, Microvention or Terumo Neurovascular now. With their superbore catheter, the Sophia 88, which will come to trial for that indication in the new year. The main issue with superbore catheters is how do you get it up there, right? So, if getting up the large aspiration catheters was difficult and difficult arch anatomy, this can be very difficult. and I don't think it's been sorted out yet. We've really gravitated to using the destination sheath, which I think is significantly better than an 8 French cook shuttle. Um, but this nut has yet to be cracked, and I think is the Achilles heel of the procedure. The last thing I'll talk about is modulated aspiration. So right now, when we attach things to a pump or we pull with a syringe, it is really like a constant aspiration. But if there's agitation, it's like there's some evidence in other body systems that that might be more effective at pulling clot out, especially on the venous side. We have yet to see on the arterial side whether that's going to work. We were involved with the Thunder study, which is run by Penumbra for their version of modulated aspiration. And those results are going to be published at the International Stroke or presented at the International Stroke Conference in a few months. So that is, I think, very exciting. And the reason I think that modulated aspiration is exciting in general is that it has the potential to move the needle on first pass success. So it's going to be more efficient at getting the clot out, but using smaller catheter systems that are easier to get there and don't have those super bore access issues as it relates to difficult arch anatomy. So again, I think this can move the needle on first pass success. We're going to find out shortly. But offers another strategy to do that. And so I'm just going to, again, end with this particular slide, which is like the philosophy that you should go into the suite with. And that is that you really want to achieve complete revascularization, not chew B3, but chew C3. Why? Because more patients do better. You want to achieve revascularization in a single pass if possible. And so you should set yourself up for that first pass to be impactful, right? And then don't dilly-dally, right? So procedural time matters. It's a vulnerable time for our patients. We want to get in and out efficiently. Again, I just want to underscore that does not mean that if you don't achieve first pass success, that it's a failure and patients are going to do well. Opening up a blood vessel in this context is the most important thing, and that's the priority. But these are the subtleties that you should aim for. Whether we're able to achieve them or not is a different story. But it's the mindset that you should carry into a case. I think that's it. Let's see.
Oh, that was great. I've had to change cameras here. I don't know if I'm on camera or not.
Yeah, I can see it. Yeah.
Oh, there we are. There we are. Yeah, no, I love that because it's very sort of step by step, all these things that we kind of intuitively believe and really showing just how impactful they are. I want to take it to a slightly different place. And one of the things that I was frustrated by was the MEVO trial. And I've just felt we didn't have the technology to succeed there. And I thought it needed to be done because there was genuine equipoise. We're going after these M2s, but we didn't have the technology. And now, particularly, I feel like everything you talked about today is actually setting us up for that. Because I think that if we have the right technology, we can succeed at the MEVOs. Aspiration and the first pass effect is doubly important in those cases because the patients aren't as their NIH score is not as high, and our failures and our complications are more evident in those cases. So the margin for error is much smaller, and all the principles that you've outlined, so elegantly and clearly, I think could allow us to move into the medium vessels.
I mean, I agree with you. I think that we were involved in one of the MEVO trials early on. I actually, it's one thing to design trials in a boardroom, right, with the trialists, and you're talking about this and that. It's another thing to be in the emergency department and you have an aphasic patient and their NIHSS is 4 and you have an accessible clot. And now you're saying I'm going to randomize them. It's just hard, right? It was hard at that point for us. And we couldn't, I felt that we enrolled one patient, then the second one, I was like, I was like, I'm so sorry. I'd never actually done that before. Well, that's not true. I did it for one of the like flow diverter trials very early on. But it was the second time out of like more than a dozen trials that I was like, I don't think I can do this. Like, I don't think I can have that conversation because I'm not sure there's equipoise here. And then of course the trial comes back as negative. And what I found interesting when you look at the three published MeVO trials is that so all of them had higher symptomatic intracranial hemorrhage rates. We were actively doing harm in the like interventional arm. But not only that, there was not only like more procedural complications, and for the audience, all these trials were like 80% stent retriever, which I think many of us sort of like abandoned a while ago, especially for these types of cases because it straightens out the vessel so much, and then you can just see bad things and perforators being torn off and like just nonsense happening. But there was also very little signal, and so like it's I don't think it's just the primary outcome of an MRS scale is like too blunt to be
Right.
able to see the benefit of these low NIHSSs. And I don't know how that is going to get resolved. And so I think it very much is left to the individual. But I think for right now, for us, for the MeVO patients, like if they have a very low NIHSS and it's not like what I would call an M1 extension, right, where it's just the inferior trunk that sort of continues and it's formally an M2, but it's really basically the like a longer M1. But like especially for like an angulated superior branch occlusion, like we're not chasing those anymore. I mean, and I think it's becoming problematic because if somebody comes in with an NIHSS of 15, are you really going to randomize that patient? Like it just the whole thing is that M2 conversation is very difficult. So my response to all that is that yes, aspiration, I think, is part of the equation, but I've caused complications with aspiration in distal vessels too. I think we need a non-stent retriever, non-aspiration strategy. Like maybe it's like a ultrasonic wire movering or some kind of infusion of a lytic where you make the clot more porous somehow. Like I think we need a new strategy to open up the blood vessel that's safer. But I don't know when or if that's going to come in my life.
Yeah. Yeah, no, I think that's very well put. Can you talk just a little bit actually about the aspiration technique? I started doing this aspiration 2015 or 2016. I started converting to aspiration, and at first I was failing at it badly. And Quill Turk was one of the first people to really start advocating it. And I asked him, what am I doing wrong? And I wasn't really engaging the clot properly. I wasn't getting close enough, and I wasn't advancing the catheter under aspiration. Are there and occasionally then it was too aggressive and pushed clot downstream, I think. Can you talk just a little bit about your particular technique for
Yeah.
aspiration? What makes it successful for you?
Absolutely, and I think I agree with everything you said, by the way. And I was very late to the aspiration game. I would actually say that it was sort of more in like 2018, 19 that we really sort of adopted it wholesale. And I remember Quill and I remember Don Fry for me was the guy that was like sort of like bigger than life in my mind, just talking about this stuff when everyone was using stent retrievers. And I was like, what is this guy talking about? And of course he was right, as it turns out. But yeah, we came to it through Solumbra, and because with the Solumbra technique, what would happen is that as remember in the old days, the catheter technology wasn't as good, and so even just to get the aspiration catheters up there, we sometimes use that grapple hook technique, right? Where you deploy a stent retriever in the clot. Like the intention really wasn't to take the clot out, but it was really to get the aspiration catheter there and you sort of pull everything back together. But I really like that idea of like when you pull, like the aspiration catheter sort of advances to the clot. And for everyone to remember that the angiographic cutoff on your roadmap is not where the clot is, right? The clot is a little bit more distal. And so there has to be like a little bit of this vacuumy energy releasing sailing effect into the clot. Now, you don't want it to, as you say, sail into the M2 or something and push the clot downstream. But there has to be some level of like, I feel engagement, which for those of you that have used which is a beautiful system, but like the Route 92 high point system, they have this like catheter on a stick for their very large, it's like super bore size catheter, but you lose with that inertia, like that natural sort of like sliding engagement of the clot. So I like very much getting up with either a delivery catheter or a smaller aspiration catheter and wire. And then as you can get to the clot or just past the clot with those systems, usually remember you're not going through the clot, you're sliding past the clot is like how most of this stuff works. And then if you take that, when you take the energy out of that and you're advancing the larger aspiration catheter up, as you take it out, if you just let the energy sort of like sail forward and engage the clot, which is usually a little bit distal to your roadmap cutoff point, I find that when that happens, I know I'm going to do what I call a high quality pass. And very often, I feel like I get good engagement. There's different techniques as things are evolving, like that Route 92 system. You have to use something slightly different philosophically. With Thunderbolt, which I won't talk too much about because it hasn't been announced. But you have to have what's called a wet to wet connection to do it. That changes a little bit how things are done. But I love it when there's that like release of energy, vacuum effect, like independent movement. Like it's sort of like your benchmark or whatever, your intermediate catheter riding up as you deploy a pipeline. It's like very satisfying, like where there's no way to cross the petrous. And then when you start actually doing the pipeline, just the natural energies in the system will make the catheter go up safely. That's what I like to see. I don't know. What do you like, Cam?
I always find it a little bit hard to judge how much dead space there is in the artery, like how far to push the catheter and to get it to get engaged. But I have been trying out the super bore catheters now, so I'm still kind of experimenting with those, and the feel is a little bit different.
Yeah.
And I suspect that they also have the advantages in that if you're a little more proximal, you don't collapse down the vessel between you and the clot as much, because you're actually the caliber is large enough to keep the vessel from collapsing and thwarting your aspiration. But the other thing I'd like to ask about before we let you go here, I see I'm keeping you past time, is the modulation. I haven't had the modulated aspirations again. I'm very interested in that, and I think that's going to be a great thing. But I haven't had the opportunity to use that yet. How many flavors of that are there, and how soon is that going to be more widely available?
Well, so there's that I know of. I'm sure there's like a dozen flavors, but that I know of, there's three. And the one that's closest to publication is Thunderbolt, the Thunder trial, which is Penumbra's version of it. And again, I can't talk about it, but because they'll present the results at the International Stroke Conference this year. But anecdotally, I'll say I'm very excited, and I love the concept that. I love the concept that you can maybe do more with less, right? And I think that if you can get up like a smaller aspiration catheter that's going to do as good a job, well, that's lovely, right?
Yeah. Sure.
Because your access is easier, everything. Again, like these large bore catheters, I think they work amazing, and they are moving the dial on first pass success. But difficult arch anatomy and tortuous common and internal cervical vasculature can make those cases very challenging, not because of the catheter itself, but because of you need an 8 French destination or Cook shuttle to get there. Putting that catheter in the common carotid artery in a type 3 arch or severe angulation of the CCA on the left can be very challenging.
Or stenotic internal carotid.
Yeah, exactly. So I think there's going to be rules, right, for the super bore catheters for modulated aspiration if it turns out that it's going to work, and all of all of these modulated aspirations. The three companies that I know that do this. I think we're starting another trial for. I think they call it rapid pivotal, but they have their own version of cyclical aspiration. Is the other word sometimes used. Is just the algorithm, right? It's like when does it turn on and off? Like how does it sense that you're in clot versus blood? Like that type of thing. So it's all software that's actually different between the different companies as opposed to the actual catheters and pumps and stuff like that.
It's fun to see how much innovation there still is. You always think that your technology is matured, but it's fun to see that there's still room for improvement there. And
So much stuff.
Yeah. All right. Really appreciate being with us this morning. That was a great talk, and really laid out a lot of important concepts nicely. So grateful to you for being here, and lovely seeing you.